All right. Well, thank you very much. And so I will go forward with the next session, which is this will be for patients who are eligible for transplant, and then disease in the frontline setting. So the first case in this situation is a 55-year-old woman who presented with evidence of bone disease, had an IgA spike of 4.6, some mild anemia, normal calcium creatinine, 41% plasma cells. This patient did have these trisomies and had, in this case, a free light ratio of 157. So for this type of a patient, what treatment would you recommend for this woman with baseline? All right. All right. I'm being told that not everyone is pressing their buttons anyway, so just press the... All right. So just make sure that you have those. Thank you. So, very interesting. 64% have selected bortezomib Landex, VRD, and so obviously one of the issues in this frontline setting is that you might want to use VRD, but do you actually have access to VRD? And so what did the faculty say? The faculty said that they would use VRD certainly if it's available, but you do options. And so what I'd like to do first is to move forward and look at, well, what are the options that we have right now that would be recommended in the frontline setting. And this is an algorithm that will be discussed further at the end of our session. So in the non-transplant setting, obviously VRD could be considered even in that setting, and an alternative for elderly or frail patients is to consider the two-drug option of RD. For the transplant candidate, VRD really is the primary recommended therapy. Moving forward, as will be discussed in the next section, with the possibility of auto stem cell transplant with or without consolidation, and then to consider some of these further options as you move through the treatment paradigm. And so what are the data related to the frontline options? VRD, or if it's available to you, VTD or VCD. Philippe will discuss his data indicating that if you have the choice, the initial early data with VTD is most likely preferable to VCD. At ASH this year, abstract number 1992, which is tomorrow in the evening, the SWOG trial will be updated, and this is the follow-up data with VRD in the frontline setting, which is one in which the VRD versus RD is offered to patients without the intent to have initial transplant, and is offered throughout the whole range of ages. And so there was no cutoff for age in this particular study comparing VRD for the first 6 months. Is in the abstract indicates that with over a 90% overall RD, and what is the continued evidence for RD is the higher occurrence of VGPR or better, 74.9 versus 53.2. And so In this follow-up, the responses brought in to review the abstract. It's very encouraging that with these current data and reviewing current eligibility, a few patients for various reasons were deemed to be perhaps not eligible. There's some minor changes in these numbers. You can see here that the overall median PFS is 41 months versus 29 months. The overall survival out over 7 years now is very interesting. You can see that still over half of the patients, 55%, have an overall survival out beyond 7 years with frontline VRD versus 69 months as a median for the RD set. Some additional details will be in the poster that's available tomorrow. What I can show you right now is we've looked at this before. The overall survival landmarked at 12 months. It does show that that longer survival is linked to the depth of the response. In this curve here, you can see that the green curve is obviously those patients who had VGPR or better. So the patients with the deeper responses are obviously the ones having the longer survival. We have also relooked very carefully at the impact of age and using multivariate Cox proportional hazard models. Clearly the benefit of VRD is evident throughout the age range. What will be shown tomorrow in the poster are actually the median PFS values for patients under 65, 65 to 75, and over 75. And so you'll be able to see for the first time these median values, which I think are very important to see the added benefit of VRD over RD in each of these three age groups. So the question becomes, VGPR is obviously better. What should be the goal in this frontline setting as we look to new variations of VRD or additional strategies? And clearly we have strong data that achieving MRD negative is really the benefit in these patients who have a CR or have anything better than VGPR, that the achievement of MRD negative, particularly at the 10 to the minus 6 level, is that level which you can see here impacts an improved PFS and overall survival, as shown here in a collective analysis of the Spanish data sets. Just to give you an update, through the international working group, there is a separate group that has been established called the I² team, which is bringing together the main individuals interested in the role of MRD as an endpoint. And just to give you an update, that the trials that will be used to help in the submission to have a review by the FDA are will be So we are optimistic that this is a package that will be looked upon favorably and that we can have MRD as an endpoint within clinical trials, which is the goal of this particular submission. There will be a similar submission for the EMA. So the second question is, if the patient is 76 years old instead of 55 years old, how does that change in the age influence your selection of the treatment? And so let's vote again. So if the patient is 76 years old and has those features that you saw before, the trisomies, the bone disease, some mild anemia, what treatment would you select for a more elderly patient? All right, so VRD is selected here, but a significant percentage moving over to RD, and also some interest in some of the newer combinations using daratumumab. So I can see a range of choices for now and then perhaps moving into the future. So if we move forward, what did the panel here thought? They used mostly VRD, although Jesus, I think, is already looking towards the future, which is what I'll talk about a little bit as I present a few slides about what we're seeing now and what can we expect, which is one of the ideas for this meeting. Where do we see those options moving? So right now in the non-transplant setting, VRD would still be the normal recommendation, with perhaps VTD as a backup, if not, but with modifications related to age, to use VRD light. Obviously, based upon the risk, which we've talked about, one would use in the higher risk patients, deletion 14. You can see 14, 16 there, which we still are considering to be a higher risk, looking towards a Velcade-based maintenance. What was striking as far as data last year at ASH was the data from the ALCYONE study where daratumumab was added to VMP, which is obviously one of the frontline choices in the non-transplant setting. And those data are very strong and showed the PFS benefit adding daratumumab to VMP. Quite revealing in that even in this setting that there was significant achievement of MRD, as you can see here, a much higher level of MRD on the right there with the addition of the daratumumab. But as is implied by Jesus San Miguel's answer, I think that we are quite interested to see data presented. Now, unfortunately, this is a message for ASH, is that this late-breaking abstract is very exciting, will be presented on Tuesday. But nonetheless, Tuesday morning, but nonetheless, these data, I'm showing you what is in the abstract, which shows a very clear benefit of the daratumumab Revlimid dex over the Revlimid dex in the newly diagnosed patients not eligible for transplant. I would also draw your attention to the median survival in the RD arm, so that you can see here that choice of RD in the non-eligible for transplant population, a 31.9-month median. So this is also an important aspect to consider, especially if you might not have access to the daratumumab. So the third question is, what difference does it make if the patient has high-risk disease? And so what I've done here is I've selected 1Q plus, 17P minus, and 1416. So if those of you, as you've seen, would be certainly features of a high-risk cytogenetic profile, how would that influence your choice? So here are your choices where you can press the appropriate number. What would you do right now if the chromosome testing is abnormal? Okay, so a lot of people would just stick with VRD. And actually, as we'll see, this is a discussion that goes between Vincent and Philippe. What data do we have that carfilzomib Lendex would be better than VRD? You can see from the panel here that all of us except Philippe say that maybe we would substitute carfilzomib for Velcade for the high-risk patient. And so we can see how this discussion goes in a few minutes. So obviously, this is the treatment algorithm that will be discussed more later, but basically you can see here that for the good risk patients, the trisomies VRD, as you move over to your right, you'll see that the choice can become KRD versus VRD, but we're really looking for those data to strongly confirm that better choice, although we all have the evidence that we've seen in many settings where Kyprolis, carfilzomib, does appear to be, in many settings, a more potent proteasome inhibitor. So what will be these kinds of controversies that we have to deal with and think about moving forward? And so I just give you some examples of questions to be pondering as we move forward and for discussion. There will be new triplets to consider, KRD, also KCD or KTD, and then of course the DARA combinations, DARA-RD, but also DARA-VD, and then substituting ixazomib versus Kyprolis. But then what will be the status of the 4 drug combinations? DARA added in with VRD, VTD or VCD, and so one can assume that those combinations, and we're waiting to see what will be the results of the Cassiopeia trial that Philippe will talk about, DARA VTD. We're assuming that adding DARA to these potent frontline combinations will be very effective. It's also important to consider, and this comes out of the Spanish VRD autologous stem cell transplant, if you're trying to do better than VRD, what is the disease that is left? And so this is a very interesting data set from the Spanish team indicating if you look at the disease in the relapse setting, there is a preponderance of bone-related plasmacytomas and also chromosome findings that are of a double hit type, 1q plus and 17p minus. So something to consider in terms of alternative backup therapy, and to look at what would be subclonal patterns, which is something we're going to be seeing more of at the single cell level. And then to look more closely at all of our options now and to think which of those would be appropriate to add in the frontline setting. Should we be thinking to add an immune therapy, selinexor, venetoclax, even CAR T cells or BiTEs in the earlier setting, perhaps as consolidation? And so certainly daratumumab, this is what's going to happen first. There is an idea that for 1114, one could consider venetoclax perhaps, but the biggest question that will be focused on here at ASH is what will be the future role for CAR T therapies and for the BiTEs. And we are faced with data that we know already from BB211 from ASCO showing a median PFS of about a year. And so the question will be, should we be harvesting T cells on our patients in the frontline setting early and then consider what would be the appropriate best time to consider CAR T cells early in the disease? And so we also need to consider how we will evaluate response, and there will be changes in the timing of MRD assessment to capture the early impact of CAR T and the bispecific antibodies. And so as we move forward, I would just close with this comment that as we look at early disease and myeloma, the way that we consider who should receive treatment for myeloma is really morphing and changing. And this is where we are right now, where we are introducing in a trial fashion therapy for smoldering disease. But if we fast forward, what would really be ideal to think about would be to look at which patients should be treated like myeloma and which patients should not be treated at all. So this is to give you some perspective of where might be we headed for the future. And so I will close with that. Thank you for your attention. Do you DARA-RD will something that we would be strongly considering?
We'll wait and look at the data, right?
If should be used at the beginning of the in lymphoma, we use a monoclonal antibody together with the best drugs. Then I visualize that in the future, probably VRD or proteasome inhibitor plus an IMiD, the treatment of choice.
Yeah, use the best treatment early. I certainly support that notion.
Really? Not
right.
one question?
No, that's all right.
Guys, you got to step it up.
Well, can I just make a comment? I just would myeloma. If you take 3 drugs and you get X% response rate or X number of months PFS, if you add a 4th drug, of course, that's going to go. And so we can't simply say that, I just increase the depth, therefore that's the best treatment, or I increase the clear in our feasible ways where cost is also a concern. Many countries where we are saying let's do DARA VRD cannot give VRD, let alone DARA VRD. So we have to be realistic. To me, the metric is you have shown with VRD Frontline a median overall survival that is not yet reached. That's beyond like 7 years. 7 years, 55% of patients are living. If you start VRD today, the first time the patient will need the next regimen, even without a transplant, is 4 years. A lot can happen in 4 years. So given myeloma is, like I've always said, more like a marathon rather than a sprint, I would like to save the best, I would like to save the most expensive drugs for later on until it's clearly shown that by using them early, you are going to improve overall survival. So overall survival should be our metric before we change. Or a head-to-head. If you did a VRD versus DARA-RD, and you said DARA-RD patients live longer, or like Dr. Kumar is doing a VRD versus KRD, and you show that KRD patients live longer, then you change. I think prematurely changing is not, I have a concern with that.
All right.
May I make a comment? You have said that the patients, the other half will relapse. As well as you about the cost and about in this audience have not even access and needs, and you need to continue to treat the patients with an alkylator. I think if we should be aware that physicians, more patients to receive.
So absolutely, in the 777 trial, what first 6 months, so using that strong early treatment is. What we're going to do is we will go back and ask again, how would you treat the older patient, the patient who is 76 years old but has the trisomies 3, 5, 9, and 15. So how would you treat that patient? And the options, we 4. All right, so we have a shift towards VRD or VRD light. So this is interesting. And then numbers, yeah, the DARA, yes. So I think then we're going to ask again the impact of the poor risk chromosomes. So the choices there, VRD, KRD, plus some other choices. Okay, so there is some movement toward KRD here. Okay, but still a spectrum of choices. So thank you for that.